Let's talk about the big kahuna in the room. What should we do? If we have diabetes, someone has been diagnosed and the sugar was 200, they came to your clinic, they're losing weight, they are peeing too much and they're getting thirsty too much, and you made a diagnosis of, let's say, type 2 diabetes. Let's keep it simple. They're obese, they're not as active, and their mom or dad has diabetes, so our typical patient. So what we do from there? So what's your go-to medications to start with? Let's say obese type 2 diabetic, Venkat. We got metformin, my favorite one. A lot of myth around metformin G. It causes kidney failure, and I tell
Cancer,
patients that
yeah, yeah,
that's
yeah.
that's not true. Yes, if they have kidney failure, we don't want to use it, but it does not cause kidney failure. But the internet, unfortunately, has pushed a lot of myth. In fact, metformin, I read a study about, I think, a year ago. If you use it, your life expectancy goes up, and you can get free at Publix. I don't know if many drugs you can get free, which increase your life expectancy. What's your take on metformin? Let's start with that. Now it's an orphan drug. No one is pushing it.
Sure. No, absolutely. It is still my first. I always ask, of course, when patients come to me, by the time they come to me, they've already been on metformin, or many of them have stopped metformin because of the GI side effects. But I always ask myself and the patient why, if they're not on metformin, why they're not, and they always try to add it. The kidney failure is not a concern in patients with normal kidney function or even moderate kidney disease. They can still take metformin, and it is a great drug to sensitize insulin, and it can also lead to, and it does not cause weight gain for sure, and very rarely it causes hypoglycemia on its own. So it's a good drug and still the number one choice according to many of the associations. But like you said, recently there's been some concern about some forms of extended release metformin having some carcinogenic effect, and that is exclusively to one few brands of extended release metformin. So there's no reason to panic. And nephrology colleagues, many of my nephrology colleagues and cardiology colleagues, they want to keep metformin as much as we can, except, of course, when they get really sick or they're getting a contrast examination or they're dehydrated or they're in the hospital, they're having a procedure, maybe they should hold the metformin for a short period of time. But otherwise, an absolutely important ingredient of my list.
Right. So metformin is, the number one prescribed drug throughout the world for this reason in obese diabetic, because, for obvious reason, it's cheap, and it helps, at least, with some weight loss, not significant, but at least it's not putting on weight, which we're going to go to next class. The sulfonylureas, that's a big problem with weight gain in that class. And the other advantage of metformin is it does not give hypoglycemia. So I think that's huge as well in certain patients, that they're not chasing their food and staying hungry. Especially with sulfonylureas in older patients, especially with kidneys not working with long-term diabetes. Sulfonylureas, we get worried in older
Right.
patients.
Absolutely.
Yes. So let's talk about sulfonylurea. Still a great class of drugs, glipizide, glimepiride, or glipizide, ER or XR. They are a good class of drugs, but older class, and still useful to add on to maybe metformin, or maybe not, depending on patient type. But still a good drug, but weight gain is a concern, so you got to balance it out.
Sure. Well, I think the one thing is I want to point out is glyburide, which is especially in our elderly population. I think that is almost contraindicated in my opinion, and I think some of the geriatric societies have also put the drug in their warning lists that we should be trying to avoid. So I do suggest that if the patient is on glyburide, they try to switch to the to glipizide or maybe even glimepiride, and glipizide being a little bit of a better choice than glimepiride in my opinion. But both drugs are fairly good, and like you said, they still have a role to play in situations wherein the other drugs are expensive and they control blood sugars. They're very strong drugs, but they're not as effective down the line. You have disease for so long, and they can cause hypoglycemia and weight gain.
All right, so let's talk about the newer classes, the Dp4 inhibitors, the Januvias, the the Truzenta and Onglyza of the world. They have definite role, and there are newer indications coming for these drugs. But the weight is always a concern with them. Where do
Yeah,
you? Yeah.
the DPP4s have really were the next big thing, weren't they, at one point about 10 years ago because of the hypoglycemia, lack of hypoglycemia risk, and they're fairly weight neutral. But I think, again, this class of drugs is fastly becoming less and less commonly used these days because of some association with heart failure with some of these drugs, especially, I mean, some of these drugs have been shown to increase the risk of heart failure hospitalization. So, although an effective way to control blood sugars, they still tend to be a little on the expensive side. So I see that the DP4 drugs being squished in between the newer drugs, which we'll talk about, the GLP-1 receptor agonists and the SGLT2 inhibitors, and the older drugs, which is metformin and SUs, and maybe some pioglitazone. The DP4 is getting very, very narrow in where we can use them.
All right, so let's talk about the sexy class, the
Yes.
expensive class, and if we can afford it, it should be put in the water of obese diabetic.
You're right about that for sure. I think these class of drugs change the landscape of diabetes management because, like you were mentioning, like you've been using these drugs, I'm sure, for a while now, and every time I start this drug, about 8 or 9 times out of 10, the patient walks into the office with a happy face, and their life has literally changed. If there is one medication that they should take and they can afford, and they go out of the barrier of injection, they should be using these. And they started with Byetta, which is twice a day, and then Victoza once a day. Bydureon was once a week. And then the game changed when the two drugs came into the market, which is Trulicity and Ozempic. And many times, because of their great advertising budgets, the patients know about this when they walk into the door, but they're worried about potential side effects, which tend to be far and few between, but there is a risk of pancreatitis. And if you have a rare form of familial history of rare thyroid cancer called medullary thyroid cancer, we should not be taking this. But that is an extremely rare condition that we don't see very often. And then on the right side, we look at the drugs which are combinations of insulin and a GLP-1 agonist called Xultophy and Soliqua. In case you need insulin and a GLP-1 receptor agonist, then you can do that with one injection. So this class of drugs has literally changed the landscape of management of diabetes because they cause weight loss, which is what any patient with diabetes would want. And they eat less. Sometimes they even do not remember if they ate or not because of the appetite suppression. Sometimes it can cause some nausea. They have to be aware, go slow, don't try to push the food beyond their limits because there is a decreasing stomach emptying with this class of drugs. But they act on different areas. They act on the brain, they act on the liver, they act on the pancreas. So wonderful, wonderful class of drugs. But like you said,
Yeah, the cost is always a
cost is a
concern, but
problem.
yes,
Right.
if the cost is not, hopefully they become generic soon.
Well, you know how that goes, but yes, that'll
let's
be
let's quickly talk, but let's not get too technical. Let's just cover them quickly. I know we are
sure.
going into technicality too much, but yeah, the SLG. These are also newer class of drugs, and they're indicated not only in diabetes and heart failure as well. So, you want to briefly touch on that, Venkat?
Sure. Yeah, these three would be the other, especially the Jardians and Farxiga have been shown to improve cardiovascular outcomes and renal outcomes. So right now, we never had drugs which can improve outcomes. Always the goal was glycemic control, get the sugars under control. But now we are focusing on how to prevent heart disease, how to prevent stroke. We want diabetes control, but we want drugs also to extend the life of our patients, to have them lead a quality life without complications. So these drugs, again, if they're affordable, would be excellent choices if we don't want injections, to take these oral pills to improve your outcomes and glycemic control and have some blood pressure control and weight loss also on top of that, although they're not indicated for that.
Yeah, I think we're going to see, in near future guidelines changing. For example, patient with diabetes and coronary disease, which is a common combination, we're going to start seeing more GLP-1 agonists start using. if they have that combination. And then, as you pointed out, with heart failure, with chronic kidney disease, that's SGLT2 inhibitors, that's going to be standard of care as the costs start coming down. And now we have more competition in the classes as well. So that will help as well. So, yeah, I think it's very exciting what's on horizon for diabetes. Let's talk about
Absolutely.
insulin. Let's just switch quickly because we spend
Sure.
a lot of time on medications. So
Right.
the insulin comes in different class. We got long acting, we got short acting and fast acting. Then we got the combination, the 70-30, 75-25. Then we got different delivery mechanism, the old fashioned syringes and needles. And then we got the fancy pens with tiny needles. And then we got different sensors and pump. Do you want to combine all that and give a brief synopsis?
Yeah, I think probably I would say that there is newer, extremely longer acting insulin analogs, which is very exciting, and some drugs, the delivery systems are getting so good that in the future, near future, we should probably be seeing an insulin which will work for a week. Now, insulins are working for 24 to 36 hours. Came from 12 to 24 to 36, almost 32 to 36 hours. And then, like you said, the short acting and the combinations in the right frame of mind. But maybe just touch a little bit on the sensors and how that is changing again the landscape. I would say the GLP-1 and SGLT2s, and then the CGM sensors would probably be the next one in terms of the shift in the paradigm. So three different ones we use: the Medtronic on the left, Guardian sensors, and then the Freestyle Libre, which is very probably easily available, and then Dexcom. The one I'm showing there is G7, which is yet to be in the market. That's the latest one. The Freestyle Libre 2 is in the middle for 14 days. You change it every 2 weeks. The Dexcom you change every week. But whatever ones you use, they will really help, and they're really helping tremendously because the pain of finger sticks is probably the most painful thing for many diabetes patients, even worse than taking insulin. And they are really, really pleased to see in the right coverage that these are covered. And then below that is the three different pumps, and the Medtronic on the left, the Omnipod, which is the tubeless pump, and then the tandem control IQ with the Dexcom G6 being the latest pump. So these are for mostly for our type 1 diabetes patients and for some type 2 diabetes patients which are poorly controlled.
Yes, so I think CGM is revolutionary. Or CGM stand for continuous glucose monitoring, and the only caveat is that if you are on more than 3 injections, so the insurances are giving a little bit hard time because they're
They are
expensive.
right.
But it's a game changer for someone who's on insulin and take more than 3 injections, because they don't have to prick your finger, as you rightly said, and then they can just wave the magic wand and they see the number right there, and they had a big bowl of french fries or popcorn with butter on it, and they say, shit, 300.
Yeah.
So
That's right.
uh,
It changes behavior. That's right. That's
yes,
the most important thing. It changes your behavior instantly because there's instant feedback.
right. And for physicians like you and me, once they bring the data, that's a gold mine. You can see what time of the day they had hypoglycemia, how much they're staying in the target. Before we get to the 3 month milestone of A1C, we have beautiful data in between that 3 months. So I think if the insurances approve it, the CGMs are fantastic for patient
Godsend.
using insulin.
They're godsend. And also the families. I mean, I have a patient right now with Down syndrome, and her grandmom takes care of her, and she can see what's going on real time wherever her granddaughter is, and so that really has changed the patients and families' lives.
Right, and we can access their data remotely as well. These are Bluetooth-enabled devices, so which
Right.
can be used as remote,
Monitoring.
kind of
Yes.
monitoring setup. So that's going to be revolutionary for patient care, as we're getting paid for telehealth visits and the remote monitoring devices. So I think they are fit in very well with that kind of care in future.
Absolutely.
We didn't touch on the a more fancy stuff, the pancreatic transplant, which is more esoteric. but more for people who have kidney failures with primarily type 1 diabetes, some early type 1.5 diabetes. But yeah, that's out there as well, but not as common. Just for completion's sake, I mentioned that.
Sure.
Anything exciting you want to bring up other than the CGM, GLP-1, SGLT2 inhibitors we talked about?
I think for those, and the prevention of type one diabetes is a very very progressive field. How do you identify people at risk for type one diabetes and enroll families, and how do you prevent that is a area of research. Islet cell transplantation, and that's also an ongoing experimental area. So yeah, a lot of and then different forms of administration of glucagon, inhaled glucagon. The inhaled insulin has been on and back and forth in terms of how it affected us and how it's useful. But that's also something to keep an eye open.
There is a question here from Mark. He's saying, can diabetes be controlled with diet alone? I'll take a crack and then you can correct me. I think
Sure.
depends on where you at with the diabetic spectrum. As we just alluded to, diabetes is a big spectrum, and you could be pre-diabetic, you could be early onset diabetic, your A1C is hovering around 6.5, 6.7, or it's 10. If your hemoglobin is A1C is more than 10 or 10, diet alone not going to do it. But that doesn't mean you should not do the diet. That diet is the first step you should do. And with the GLP-1 agonist like Trulicity and Ozempic, patients are realizing they're losing weight, and then they start you know becoming more active and exercising more, and the diet improves because they see positive reinforcement of that class of drug. But diet alone is fantastic for pre-diabetic, absolutely, along with exercise. But as the sugars start going up and your insulin resistance start increasing, diet alone maybe not the only modality, right?
Sure, I think yeah, absolutely that the type of diabetes you have, make sure you don't have the type
Type 1.
1.5s or 1
Yeah.
or 1.5s we talked about. You can look like a type 2, but you
Mhm.
might not have type 2. So make sure you're not one of those by getting the testing appropriately in the situation. The second thing, like you mentioned, where you are in the duration and the stage of the disease. But what is very important for me to probably highlight is the initially when you are diagnosed with diabetes, there's a lot of glucotoxicity, so lipotoxicity. So your pancreas is in a shock. So I would not focus on what I'm taking. I don't want to take any medications. I want to do a diet at that point, because no matter what you do, your pancreas will not make insulin for a period of time. So you shouldn't. I ask my patients to get over that, take the whatever is required, do the diet, exercise, and medications, bring the sugars down, and let the pancreas heal. And once it heals and starts producing insulin, you will see the change, and you'll feel better, and you'll back off on all the medications. So the answer to the question, yes, but not immediately. So eventually, yes, but like you said, you have to go through the phases of correction the toxic situation first, and then stop the medications later on potentially.
Let's just wrap up, Venkat. I know we spend in details, and thank you for being so detailed, because
Absolutely.
you can do a whole fellowship on diabetes.
Right. Absolutely. We
And
try to
we
cover everything in 1 hour.
we try to cover it in a very short period of time. Well, let me just bring up a few things which we do in primary care. I'm pretty sure you do at your end too. If you're diabetic, make sure you get annual eye exam.
Right.
So that's part of the care. We covered medication, lifestyle. Let's uh, focus on what else we should do if we are diabetic. So annual eye exam is critical, because even you are pre-diabetic, you may start seeing changes in your nerves, which is neuropathy, or in your retina, even before you become diabetic. So it's critical that once a year, when you go to see your ophthalmologist or optometrist, and if you're pre-diabetic or diabetic, make sure they dilate your pupil, not just just cursory exam, but dilate your pupil, look at your retina, and that can save retinal hemorrhage, blindness down the line. So very critical to emphasize once a year annual eye exam, or more frequently if you have unfortunately developed diabetic retinopathy.
Absolutely.
So that's one. And then the second end of the spectrum, from head we go to foot.
Right. Most
Make
important part. Yeah.
most important. If you don't have that, then it's a very big handicap. So
Right.
you look at your feet. A lot of folks who have diabetes for extended period of time, even pre-diabetes for extended period of time, they can get neuropathic and they lose sensation of touch and pain at the bottom of your feet. And that part of the skin, unfortunately, that part of the organ, the foot, is not very vascular. So God forbid you get a sore up there or some foreign body up there, and you're diabetic. No matter what we do, sometime it won't heal, and you end up getting amputation because of poor wound healing in diabetic, higher sugar, higher infection, and less wound healing. So it's very critical to moisturize your feet. Look at your feet twice a day. You know, think of your feet as your girlfriend when you're young. You bring roses to your girlfriend. You bring chocolates. So bring moisturizer to your feet twice a day. Look at it twice a day. Make sure there's no sore. And then get an annual a foot exam, either at your primary care office, endocrinology office, or podiatry office. But get an annual foot exam to make sure you're not getting neuropathy, or if you're losing hair in your legs, or the feet is getting cold. That's the other aspect of diabetes. You get more circulatory issues or poor circulation. So very important to get them addressed early on. And diabetes can cause serious circulatory issues. So examine your foot, touch it, see if it's cooler, or you're losing hair on your skin. These are all telltale sign of the circulation not being good. So get that looked at too. Anything else you want to add to annual preventive maintenance in addition to the foot and the circulation and the eyes?
Yeah, I was saying, looking at other things like aspirin use in the right setting, if you are a cardiovascular risk, of course, controlling your comorbidities like cholesterol, blood pressure, skincare is very important, and because that tends to be a big problem in many of our diabetes patients, and mental health, as well as back pain. And these pain issues are really huge in many of our diabetes patients. So looking at those kind of things, and in the right setting, maybe even looking at cardiac evaluation, your risk of cardiovascular disease, talking to your primary care doctor about whether you would be a good candidate for identification of one of the cardiac risk scoring and other issues. So those would be the main things. But foot, feet, and eyes are absolutely critical for every diabetes patient.
We missed on one area, which I know you're a big fan and I'm a big fan, is to get help from dietitian.
Right.
Uh,
We are
and
not dietitians, by the way, right? So we professionally we need advice from them for sure.
right. So if we can make them part of the team approach, especially when you're newly diagnosed or you're struggling with controlling your sugar, it's very difficult, unfortunately, with insurances to get a dietitian on board.
Right.
Except for if it's 10-hour class or something. I wish the insurances are a little bit more liberal with getting dietary consultation. I think we'll have better
Yeah,
outcomes.
absolutely.
But that's a challenge. But if we can access them, I think dietitians are fantastic resources in maintaining food diaries and helping stay on the program and adjusting their day-to-day dietary, what they're consuming, and improving that. So I think
Absolutely.
dietitian is a important piece of team approach.
Absolutely. Diabetes education by a certified diabetes educator and a nutritionist and a dietitian as part of the team is critical. And I think, like you said earlier on in the disease, if they can get that 1 hour class, and like you mentioned about the insurance coverage and those barriers, if they can be crossed, and that is critical in terms of not only type 1s, but type 2 diabetes patients also. They just become changed patients once they get that education, the detailed education about a meal planning, and their eyes suddenly open. No, I didn't know that was bad for me. I didn't know I was eating this bad. So The devil is in the details because it's part of our life. It's part of what we do every day. So you can just have a 10-minute consultation with your doctor and try to change your life. It's very, very difficult, isn't it?
All right, let's summarize. I'll give 5 points I learned from you, and you tell me if I missed something. So
Sure.
number one is early diagnosis. If you symptomatic or you have family history, please get it checked early, and make it part of your annual physical to get your fasting sugar and A1C. Number two is diet. What we give ourselves is who we become. So consuming less processed food and fast food, and consuming more fiber in your diet, more plant-based diet, more Mediterranean diet, whether you're diabetic or pre-diabetic or gestational diabetes, or just want healthy lifestyle, will help you. Number three, adding a little bit more physical activity, in this COVID era where everyone is using screen time, whether we are children or office goer, we are, so put an alarm on your computer, maybe every 30 minutes, every 15 minutes, take a break and have a sip of water, and take a walk. Number four, if you've been diagnosed with diabetes, um, just understand it's not a sprint, it's a marathon. Don't get overwhelmed. Follow the instructions of your physician, whether endocrinologist or primary care or diabetic educators. Stay on course. And last not the least, look at your end organ damages, which can happen. So see a ophthalmologist or optometrist, or see your endocrinologist on regular basis, or physicians, allied services, to make sure you're not getting any complications. And if you catch them early, for example, you mentioned coronary artery disease, or atherosclerosis of the abdominal aorta, like abdominal aortic aneurysm, or any part of the body could be affected by the calcium buildup and hypercoagulable state of diabetes. So if you can catch it early, your outcomes will be better. And other than that, I think you can add anything else I missed.
No, no, absolutely. I was going to get very non-technical here at the end. I was going to say the three things I would like to highlight is prevention, obviously, is better than cure, applies to this more than anything else, because once you get it, it can be a very, very difficult process. Number two is hope. Don't lose hope. I think there is plenty of options available in case you need to be on medications. There's wonderful medications, so don't get despondent, and your life is not, you can lead a normal life as much as possible. Number three, I think, is community. I think we should involve more of your friends and family and all the virtual resources you can have, so that you can learn from others what everybody is doing and get support, because mental health and then coping is very, very important. So, in addition to all those three things, I would like to add those three things. And yeah, thank you very much.